Good afternoon, everyone. Welcome to the ASPPH hosted webinar on the latest supplemental issue of Public Health Reports, the official journal of the Office of the U.S. Surgeon General and the U.S. Public Health Service. Thank you for taking time out of your busy schedules to join us for today's webinar. My name is Dr. Hazel Dean, and I am the Editor-in-Chief of Public Health Reports. I would like to welcome you to the webinar on behalf of the Public Health Reports team, including our managing editor, Dr. Andrei Kuzmachev. Published since 1878, Public Health Reports is the oldest public health journal in the United States. Public Health Reports is dedicated to publishing original research, reviews, and commentaries in the areas of public health practice and methodology, public health law, and teaching at schools and programs of public health. Public Health Reports' most recent supplement issue focuses on the public health response to human trafficking, a look back and a step forward. On behalf of the journal, welcome. Before we begin, a few items of note. The session is being recorded and will be available on the ASPPH website shortly after the conclusion of today's webinar. Please note that attendees may receive continuing education credits for Certified in Public Health. You can ask questions or submit comments in writing at any time during the presentations by clicking on the Q&A button at the bottom of your screen. We will hold questions until the prepared content has been presented. Professionals working with and serving communities at risk of human trafficking increasingly use public health strategies to establish evidence-based, data-driven responses to human trafficking. The Public Health Response to Human Trafficking, a look back and a step forward, published by Public Health Reports and sponsored by the Office on Trafficking in Persons, expands the current evidence base and highlights the strengths of using a public health approach when preventing and responding to human trafficking. The authors in this supplement explore the efficacy of individual and communal public health interventions and describe the tools used by professionals and systems of care to respond to human trafficking. Join us for a discussion of this supplement issue of PHR and hear directly from those involved in the development of the supplement and the authors of 2 articles. Before I introduce our panelists for today's webinar, I would like to share a brief message from Katherine Chan, Director of the Office on Trafficking in Persons at the U.S. Department of Health and Human Services, which sponsored this supplement.
Good afternoon and welcome to our distinguished panel of authors and invited guests. I'm Katherine Chan, the Director of the Office on Trafficking in Persons at the U.S. Department of Health and Human Services. I would like to thank the editorial team and the Association of Schools and Programs of Public Health for their partnership in publishing the first ever public health report issue on the subject of human trafficking. The Office on Trafficking in Persons sponsored this supplement to commemorate the 20th anniversary of the Trafficking Victims Protection Act. Since the legislation's initial authorization in 2000, our methods of addressing human trafficking have evolved, and the understanding that human trafficking is a public health issue is much more widespread. The Public Health Reports is the official journal of the Office of the U.S. Surgeon General and the U.S. Public Health Service. We want to acknowledge and thank the U.S. Surgeon General for his leadership and partnership. The supplement issue, The Public Health Response to Human Trafficking, a look back and a step forward, aptly characterizes this point in time. It describes what we know, what we don't know, what we need to know, and why we need to know it. This supplement illustrates the importance of public health research to identify evidence-based practices to effectively assist individuals who've experienced trafficking, understand human trafficking victimization to inform targeted prevention and early intervention activities, and make data available to those who want to address root causes and systemic inequities. As we continue to develop and strengthen the public health response to human trafficking, we must remember the importance of multidisciplinary collaboration. The Office on Trafficking in Persons contributes to a whole of government approach under Presidential Task Force on Human Trafficking and the recently launched HHS Task Force to Prevent Human Trafficking. Our efforts to advance knowledge of human trafficking include partnering with the HHS Office on Women's Health and the National Academies of Science, Engineering, and Medicine to understand human trafficking prevalence methodologies, funding field testing of prevalence methodologies within the construction industry to contribute to a global collaboration hosted by the Department of State, disseminating information on validated human trafficking screening tools for use in healthcare and child welfare settings, and collecting and analyzing incident reports of human trafficking victimization. No one can prevent or address human trafficking alone. All of us, government agencies, researchers, service providers, individuals with lived experience, must contribute. By working together, we will be better positioned to reduce the impact of trauma across a person's lifespan and across generations. We are pleased that you could join us today for this presentation and discussion.
On behalf of U.S. Surgeon General, Vice Admiral Vivek Murthy, I want to thank our panelists for joining us today. The supplement's guest editors, Dr. Jenny Sprang, Professor of Psychiatry, University of Kentucky, and Executive Director of the Center on Trauma in Children, and Dr. Hani Streklosa, Chief Executive Officer and co-founder of Health Education Advocacy Linkage, or HEAL Trafficking, and Assistant Professor of Emergency Medicine at Harvard Medical School. And we are so pleased to have two authors sharing their articles. Dr. Michaela Cook will share findings from her article addressing racism in the domestic minor sex trafficking of Black girls, the role of public health, critical race praxis. And Dr. Anka A. Vujanovic will share findings from her article, Applying Telemental Health Services for Adults Experiencing Trafficking. It's my pleasure to introduce Drs. Jenny Sprang and Hani Streklosa.
Thank you so much, Dr. Dean. First, I want to acknowledge our co-guest editor, Dr. Jordan Greenbaum, Medical Director of International Center for Missing and Exploited Children, who was unfortunately not able to join this webinar today. Jordan, your stalwart, tireless energy and wisdom, tenaciousness helped us bring this issue to the finish line through a pandemic. No small feat. Thank you. So this is a thrilling moment for me. If you had told me 20 years ago that we would be having this webinar to commemorate a special issue in public health reports on trafficking, I would have called your bluff. When HEAL Trafficking was founded, our initial aim was to transform the trafficking movement to one grounded in public health. We know that we will never be able to arrest or prosecute our way out of trafficking. We believe the only way to end trafficking is to do the work to address the root causes of trafficking and build communities where everyone is allowed to live and thrive. The title of this special issue is The Public Health Response to Trafficking, a Look Back and a Step Forward. So I'm going to start off here by talking through a reflection of the look back piece and then kick it over to my colleague, Dr. Sprang. This special issue commemorates the ways in which public health strategies are driving human trafficking research today. Here, we see investigations using sophisticated methods of prevalence estimation, the design and validation of screening tools, and the use of sentinel surveillance to detect trends in human trafficking. While much research focuses on identifying risks and vulnerabilities at the individual and relationships level, there is also an increasing focus on studying cultural factors that influence human trafficking at the societal level, including studying systemic racism and other beliefs and attitudes that foster the marginalization of large groups, including homophobia and transphobia. At the same time, we also need to acknowledge that the public health research on human trafficking is still in a formative stage of development. It is strongly affected by history, politics, international trends, and other sociocultural, legal, and environmental conditions. All of these influence research priorities, funding, and even key definitions. As co-editors, we see where the state of public health research on trafficking falls short. Despite the fact that labor trafficking is more common than sex trafficking globally based on current prevalence estimates and comes with significant health and mental health adversity, most United States-based research has focused on sex trafficking. There's relatively little peer-reviewed published research on labor trafficking globally and only a handful of studies here. The lack of research on labor trafficking, including rigorous US prevalence estimates on labor trafficking, is consistent with historical inequities seen throughout the history of the United States related to the devaluing of people of color, including immigrants of color. Unfortunately, the disproportionate focus on sex trafficking is evident in our supplemental issue, signaling the need for continued efforts to raise awareness of forced labor as an important area of research and to advocate for funding to support this work. Trafficking research has focused heavily on the experiences of cisgender women and girls to the detriment of individuals with other gender identities and varied sexual orientations. In society, a heavy emphasis on sex trafficking and the strong influence of machismo gender roles partially account for the lack of data on male exploitation, as cultural stigma and discrimination partially explain the paucity of data on transgender and non-binary populations. These make for serious gaps in our knowledge of risks, vulnerabilities, protective factors, and service needs of large numbers of individuals, many of whom are at especially high risk of trafficking and exploitation. A third criticism of existing research on human trafficking highlights the paucity of studies that disaggregate data by sex and gender, that compare characteristics of labor versus sex trafficking, that examine the interaction of labor and sex trafficking, since we know that many people experience both types of exploitation. These gaps in research may lead to false assumptions. So, for example, the belief that boys cannot be commercially sexually exploited leads to ignore potential signs of risk and vulnerability among males. We don't see what we're not looking for. So we conclude there are very few males experiencing sexual exploitation, which reinforces our original false assumption. This is just one example. The gaps in research also may lead to inappropriate generalizations. So, for example, the false belief that all individuals experiencing trafficking have the same risk factors, which can then in turn lead to ineffective prevention and intervention efforts. That is, we may build our programs on false assumptions and erroneous conclusions. So I'm going to kick it over to Dr. Sprang to help us look forward.
Thank you, Hani. As we look forward to the next generation of trafficking studies, we have both an opportunity and a responsibility to reflect on and learn from the past. Our anti-trafficking response, including the research funding mechanisms, trafficking data, and even the interest of researchers, has been shaped by the forces of structural racism, misogyny, and xenophobia. As a team of co-editors who are white, cisgender, US-born women in academia without a lived experience of trafficking, we want to acknowledge the inherent privilege and biases we bring to our analysis of the state of public health trafficking research. And we try to be acutely aware of this during our work. But bearing this in mind, we offer these recommendations based on the synthesized results of the supplement. First, future research should be based on equity-grounded theories that address trauma, interpersonal violence, as well as social determinants of health. We really need to think thoughtfully about how we determine our hypothesis, how we design our studies, and how we address potential confounders and biases. Our research should be critically appraised for its rigor, objectivity, its accuracy and interpretation of results, and its consideration of social and historical context. Second, research should be designed and implemented with the input of affected communities, including those with lived experience of trafficking and those that represent at-risk vulnerable populations. We need to use established community-based participatory research methods that allows these voices to be included in the design and implementation of study protocols. Every effort should be made to center the voices of those at the margins of US society. Third, balance measures used to assess for unintended consequences should be developed in partnership with people affected by trafficking-specific interventions, such as adults engaged in commercial sex and undocumented migrant workers. We need to be acutely aware of what Robert Merton referred to in 1936 as the unintended negative consequences of purposive social action. And finally, our research agendas should be shaped by diverse stakeholders, including academic researchers, mental health and public health practitioners, policymakers, and advocacy organizations. Public health research, if conducted rigorously and with a focus on equity, has the power to change the systems and structures that allow human trafficking to persist and propagate. And if we didn't believe that, we certainly wouldn't have embarked on this journey of editing this special supplement. So this supplement aims to build the evidence base for human trafficking prevention and intervention and elevate the importance of a strong public health response to human trafficking. As guest editors, Drs. Greenbaum, Stoklasa, and I sought to highlight innovative strategies for human trafficking research, prevention, and service delivery. So we were looking specifically for research that would lift the field to the next level. And the studies in this supplement do just that. They cover a broad range of topics, including a comparison of public health methods for estimating the prevalence of hard-to-reach populations, a look at the relationships between commercial sexual exploitation during adolescence and health over the child's life course, and the design and implementation of a collaborative, multidisciplinary, citywide victim services model that focuses on health care for those who have experienced human trafficking. So today we are fortunate to hear from the authors of two of the studies included in the supplement. And so now I'd like to turn it over to Dr. Cook, who will highlight the first of these papers.
Good afternoon, and thank you for the invitation to present. So the title of my presentation today is Addressing Racism and Domestic Minor Sex Trafficking of Black Girls, the Role of Public Health Critical Race Praxis. I was funded through my Career Development Award to conduct this study, and I have no conflicts to disclose. I think it's very important to acknowledge the people that contributed to this work that's been years in the making. First, my co-authors and I would like to identify all of the survivors that have contributed their voice, their stories, and their information to helping us better understand the plight that they've experienced. On screen, I have my co-authors P.T. Lee and Jennifer Garcia, who labored with me in using the right language and trying to capture this idea in a way that will hopefully advance the field. Also to our research assistants, mentors, and certainly our family members who might not know exactly everything that we do, but have supported us throughout this endeavor. So the purpose of our paper was really to expand upon the current conversation about the role of racism in human trafficking, to introduce the field to additional tools to addressing racism in human trafficking, and also invite colleagues to, in the work, to critically examine our current approaches to prevention and service provision. So it's important to start with the definition so you understand what we are referring to when we say domestic minor sex trafficking or DMST. And we define that as the commercial sexual exploitation of a minor under the age of 18 in the United States. In our work, we draw from several frameworks, but we specifically focus on the public health approach and critical race theory. And we are building upon the foundational work that has been completed by several researchers that were a part of this collective special issue, notably the 2017 published book on entitled Human Trafficking is a Public Health Issue, which was edited by Dr. Chilsum Staker and Dr. Stoklosa. So what is public health critical race praxis, or PHCRP? PHCRP builds upon critical race theory, which is a race-conscious movement to examine all levels of the legal system and legal practice. In public health critical race praxis, we use a framework that combines science, theory, experiential knowledge, and action to pursue racial equity in public health research and practice. Other than the focus on health, one important distinction is that PHCRP also provides practical ways to initiate and implement changes. This figure is provided by Drs. Ford and Erhan-Bua, who coined the term public health critical race praxis and provided this diagram. And the purpose of showing this was to just show the interconnected nature of PHCRP. And the primary takeaway is that all four affiliated focuses, contemporary patterns of racial relations, knowledge production, conceptualization and measurement and action, and the associated principles that fall underneath each of the focuses are all within the sphere of race consciousness. In other words, each application of PHCRP is first rooted in an awareness of and attentiveness to the racialized dynamics in society and the contribution of these dynamics in the work that we do in trafficking prevention. So what is considered a racialized society? Well, in the public health critical race praxis, we understand race is a socially constructed concept that elevates whiteness in the social hierarchy. As a function of this racialized social hierarchy, there are ingrained benefits and privileges for people who are closest to the top of the hierarchy. So if that is the way a racialized society works, then in a country like the United States, the social construction of race matters. Not only does it matter, race is also connected to economic opportunity and access to certain resources. So that kind of leads us to trying to understand, how do we apply this idea, PHCRP, to DMST, or domestic minor sex trafficking? Well, I'm going to go through the four focuses of PHCR, public health critical race praxis. I don't have time to go into as deep of a discussion as I'd like to, but hopefully in our question and answer, we'll have a chance to delve into some things a little deeper. So the first focus is contemporary racialization. And contemporary racialization considers the racial and historical context to understand how racism and racialization operate within a specific and given time period. So in the paper, we talk about contemporary adultification of Black girls. And this is the misconception that Black girls are less innocent and more adult-like than their white counterparts. In our paper, we provide an example of the case of Centoya Brown as an indication of how Black girls are perceived by the juvenile justice system or the justice system at large. And very briefly, Centoya Brown in 2004 was a 16-year-old girl who today would have been considered a domestic sex trafficking survivor. She, in 2004, shot and killed her 46-year-old John after exchanging sex for money. And at the time, she was later sentenced to 51 years in prison without parole. This story caught national attention, and something that I wanted to highlight was that the prosecutor in the case said that at age 16, quote, cruelly and mercilessly Cetoya Brown executed. Now, this is in spite of her history of abuse, her history of experiencing rape. Certainly, the trafficking nature of her situation was not included in her trial. Brown would later receive clemency from the then governor of Tennessee. The perception of the court was that Cetoya Brown was old enough to understand her actions and thus was deserving of 51 years in prison, the adultification of a Black girl. The next focus is called knowledge production. And in knowledge production, it asks researchers and practitioners to question how anti-sex trafficking efforts are shaped by racialized beliefs and uncover ways in which we are unintentionally reinforcing racial bias. Again, using the adultification of Black girls as an example, if the common assumption or belief is that most Black girls are ready for and engage in sex at young ages, when their recruitment, seduction, and enticement into trafficking, it may go unnoticed. And so their victimization as a domestic minor sex trafficking survivor may not be noticed if we are holding to these beliefs that girls are ready for and engage at sex, Black girls are ready for and engage at sex at younger ages. Similarly, because of racialized beliefs, the adultification of Black girls, those who are recognized as survivors may be blamed for their victimization because Black girls know what they are doing and they're making the active choice to do so. And we will get into a conversation because I want to highlight the importance of the dialogue that is happening in the sex trafficking field about victims versus survivors versus choosing to engage in sex work. And there are important distinctions that need to be made. But for the purposes of this, this paper, we highlighted victimization and chose this word intentionally to highlight some of the challenges that are faced with understanding Black girls can be victims of sex trafficking and don't always make the choice to engage in sex work. And I'd like to highlight an important article by Gerasi, Colgrove, and McPherson in their 2018 article that talked about the associated, that highlighted the associated principle of critical approaches. And once we have become aware of our knowledge production and examine our current accepted beliefs in the field and understand maybe underlying bias, we have to challenge our agencies and ourselves to move the field beyond that status quo. And in Gerasi's, Colgrove, and McPherson's article, they do this. The third focus is conceptualization and measurement. And this highlights the need to clearly operationalize race, specifically racism-related constructs in DMST research. There have been several calls in this special issue included to improve methodological approaches to human trafficking research. More studies are needed to measure intersectionality-related factors in surveys. Relative to the volume of articles published on sex trafficking, few studies articulate the role of racism in the vulnerability to DMST, let alone attempt to measure how racism as a construct. We need to consider developing theoretical frameworks and conceptual models that include racism constructs. For example, with a large population-based study, that included trafficking-related questions, a researcher could assess how racial residential segregation might be associated with domestic minor sex trafficking. Another example, in qualitative research, we need to inquire of survivors that are participating about the role of race both in domestic minor sex trafficking and the experiences of racism they have in the life and with service providers. The last focus is action. And in the field of public health, we aim to not only conduct the research, but also apply what we've learned to evaluating and reevaluating our approaches. So in action, it's the application of the new knowledge gained from the previous focuses. This includes disciplinary self-critique, again, making sure victimization, I'm sorry, that's a typo, but understanding disciplinary self-critique. And as I mentioned before, the Gerasi, Colgrove, and McPherson article really highlighted critiquing their approach to offering services. And they had multiple experts that were a part of the process, including the survivors. So I do again highlight this article. And in conclusion, while our focus of our paper was on Black girls, we acknowledge and encourage PHCRP be applied to improving service provision to all survivors of both labor and sex trafficking. I want to thank you for your time. I apologize for how quickly I had to get through this. Here are some selected references, and I look forward to our discussion following the next presentation. Thank you.
Good afternoon. Good afternoon. Thank you all. Can you hear and see me okay? Looks good. Okay. All right. Good afternoon. Thank you so much for the opportunity to be here. It's a real honor to share our work with you. And I'd like to start by acknowledging my amazing collaborators on the commentary for public health reports. They're all listed here, and they're faculty at Baylor College of Medicine and leading the anti-human trafficking program there since 2016. The program was created in collaboration with the City of Houston Mayor's Office, the Office of the Governor of Texas, and community partners to address the urgent needs of Houston area victims and survivors of human trafficking. And my collaborators really brought so much depth of expertise to this commentary, which was a product of their frontline experience providing mental health services to people experiencing trafficking during the early COVID-19 pandemic. And hence we wrote about applying telemental health services for adults experiencing trafficking. Just a brief note about our funding, and no further conflicts of interest to report. So our aims really in writing the commentary were to provide clinical perspectives, multidisciplinary clinical perspectives, and to offer special considerations for applying telemental health to assessment and treatment of people experiencing trafficking, to consider the perspectives of both patients and providers in doing so, to discuss future directions, and of course, to enhance awareness and stimulate discourse on this very important public health topic. So human trafficking is generally defined as sex and labor trafficking, forced labor, debt bondage, and other forms of involuntary and illegal servitude, and that's to what I'll be referring throughout. Affects more than 40 million people globally. And we're seeing an increasing awareness of the public health significance of trafficking. And there have been several overarching public health responses to this crisis that have been developed, emphasizing primary prevention, education and outreach, education of healthcare providers, multidisciplinary providers, emphasizing interdisciplinary models of care and specialty clinics. Mental health is a significant public health issue affecting people experiencing trafficking, who often experience very high rates of various psychiatric symptoms and conditions, post-traumatic stress disorder, substance use disorder being among the most common. There's a relatively scarce literature on effective mental health assessments and treatments in this population, although we are seeing mandated clinical trainings for licensed providers nationally increasing, and we do see agencies starting to develop and refine response protocols. There are various barriers to mental health care, some of which Dr. Cook discussed, and they operate on systemic levels, provider levels, and individual levels. On a systemic level, there's really a dearth of empirical literature, fairly inadequate organizational policies and procedures, generally speaking, and few providers with specialized expertise and training in this population. At the provider level, misconceptions, biases, issues of racism, racial discrimination, as Dr. Cook mentioned, limited experience with complex clinical presentations and that intersectionality of various social determinants of health, the clinical presentation, and the individual level, safety concerns, physical concerns, financial problems, shame and stigma, cultural linguistic barriers, a lack of awareness or insight into the symptoms they may be experiencing, and then just a general potential lack of knowledge about mental health care. What is it? Where to go for help? And hence this brought us to the idea of telemental health. So using available technologies to provide mental health services to this very underserved population, and being a potentially promising pathway to improving treatment access and addressing some of those barriers that have been identified. And telemental health services may include various kinds of disciplines: psychologists, counselors, psychiatrists. And, we do have, research evolving that shows that introducing telehealth services in healthcare systems broadly tends to increase healthcare use while maintaining in-person contacts. And so telemental health may supplement in-person visits and may offer treatment continuity for people experiencing trafficking. So telemental health interventions have been found to be comparable to in-person interventions across various randomized clinical trials for treatment of post-traumatic stress disorder, depression, substance use disorders, anxiety conditions. And really, for survivors of interpersonal violence, or IPV, probably the population closest to what we're talking about, there's a growing literature on telemental health that's promising. And these telemental health interventions for IPV have demonstrated feasibility, acceptability, but most studies have focused on computer-based screening, education, safety decision aids. And so the strengths of such interventions include instant confidential access to resources, and the ability to tailor such interventions to individual needs, using limited to no human resources. But we really need more work both on IPV survivors broadly and on people experiencing trafficking. And indeed, we found no empirical published research focusing specifically on the use of telemental health services for people being trafficked. So at the beginning of the pandemic, this was really an issue that providers working with this population were figuring out as they go. And so we found that really this could, telemental health could increase access for patients. People experiencing trafficking could gain much greater access. It would eliminate the time and cost associated with transportation to appointments, childcare needs, limited medical leave or time off, or allowable time away. Individuals experiencing trafficking may keep non-traditional schedules and hours, and telehealth modalities would provide greater scheduling flexibility and continuity of care, given geographical relocations, even within the same city. For some, telehealth services may provide greater convenience and safety, since they could access care without having to show up or travel somewhere in person, and they may get the advantages of integrated care through systems. Telehealth modalities could also address privacy and confidentiality concerns that many people experiencing trafficking may have. So meeting with providers via phone, video, or text might provide greater privacy than in-person services. And certainly hotlines and text lines can provide complete anonymity and can also facilitate access to language interpreter services, since interpreters could be scheduled to join calls remotely. And again, not requiring travel could ease access. It could also enhance efficiency for providers, offering built-in efficiency and boundaries. Log-ons, log-offs are at set times, visible to both provider and patient. Individual, group, and family services can be conducted, psychotropic medication management as well, intake mental health evaluations, and ongoing assessments of functioning and risk could be conducted. And continued remote access to patients for providers who can't get to the office due to inclement weather, COVID-19 quarantine, underscoring this idea of continuity, reliability, and predictability. So underscoring this potential for really emphasizing the trauma-informed care approach. But, this kind of approach does require clinical centers to provide funding for relevant hospital and clinic administrations and health insurance providers, and all of the pragmatic details. So those are kind of the pros of telemental health services. Now I'm going to talk about some of the challenges that are important to consider. The first is that telehealth services require patient access to and familiarity with technology and the internet. And certain subsets of people being trafficked may have access to mobile phones, while others may not have access, and the use of mobile phones or technology may be very uncommon in their trafficking scenarios, such as those in agriculture, construction, or manufacturing. Furthermore, technology may be a barrier for people with traumatic brain injuries, memory impairment, limited education, or even trauma histories that were associated with the use of technology. Using technology may become a trauma cue and a barrier. It's important to note that telehealth can increase safety risks depending on the level of power, control, and intimidation exercised by traffickers. So traffickers may monitor use of phones, pay for cell phones or internet use, monitor it, maintain access to patient phones or computers, and threaten to or actually harm persons who have unapproved contact or secret devices. And so for providers, risk management considerations are key when considering telehealth platforms. Informed consent obviously is a pillar of any mental health service provision, especially important for this population. Providers and patients should establish transparent, mutually agreed upon limits to confidentiality, and breaking confidentiality to address imminent risk may translate to increased risk of harm to the patient, harm perpetrated by traffickers. So following best practice guidelines, use of patient set passwords or specific patient set danger, code words can be integrated into sessions, as well as risk assessments at each session for various potential behaviors and issues. And obviously monitoring and providing consultation to mental health providers because burnout and fatigue may be an issue for them. So in terms of future directions, we really need to know, are telemental health services effective? And then for whom, how, and under what circumstances might such services be most effective and appropriate? And so evaluating social determinants of health and how they may impact treatment initiation, access, and completion. Integrating person-centered, trauma-informed, culturally sensitive interventions. Evaluating the utilization of telemental health services in real-world settings. Using qualitative and mixed methods approaches. So talking to people who are experiencing or have experienced trafficking about their needs, preferences, acceptability, and barriers. Comparing different delivery methods, phone versus text versus video, for example, and then really empowering individuals with patient preferences, making patient choice the central issue, helping them to improve perceived controllability over their care and enhance trust in providers and systems. I'd like to conclude by thanking the individuals who experienced trafficking, who trusted us with their stories, struggles, and mental health care services. And I want to thank you very much for your time.
We will now take questions from our audience. You may type your question for any of the authors into the question box at the bottom of the screen. I'll start off with the first question. For Dr. Cook, according to US law, there is no consent to sex work for a minor. Minors are per se victims of trafficking, regardless of race. Can you comment on how well you think this is understood?
Well, the first question is controversial. Thank you for the question, because this is an ongoing discussion in the field of sex trafficking to understand at what point does a person have agency. And I don't have a specific answer, a straightforward specific answer for that, because legally, if we approach it from a legal perspective, you're correct that as an adolescent, you don't have the right to engage in commercial sex work. But from a public health perspective, we reorient to the individual, and it's important to understand where that person is coming from first. And as a prevention specialist, and certainly from the work that I do in understanding structural racism and oppression and lack of opportunity, I sometimes ask, how much were you actually making that choice? When people say, yeah, I know I'm choosing, if there are limited access points to resources or other forms of gainful employment. So, I'm looking at it from a larger perspective, and certainly not from the legal perspective. I make that very clear distinction that this is very much so from a public health perspective, and also at the individual level. So it's a tough question, and this is an ongoing discussion, I believe, within the field. And it kind of goes back to what I was mentioning about using the terms victim versus survivor versus engaging in sex work.
Thank you very much. Our next question, for Telemental health services, how is it suggested providers should best assess for safety before continuing with conversation?
That's a great question, and really an empirical question, right? This is exactly to the heart of the matter of why we need more research on this. But for right now, what we suggested in the commentary is having those conversations about confidentiality and informed consent early and often in the patient-provider relationship, giving as much choice to the patient as possible, explaining very transparently and assuring understanding of legal parameters around imminent risk and what the provider would need to do. And as I mentioned, maybe making sure to use passwords or maybe danger code words that aren't obvious for the person if they're in an immediate risk situation, that they can use a word to alert the provider. But I think risk management is a central issue with telemental health generally, and this is a very, very high risk population. So I would really like to see a lot of research, especially the mixed methods research, where we're asking the people experiencing trafficking, we're interviewing them, we're asking them for their input on what would make this feasible and practically viable for them, given varying circumstances.
Thank you so much. This is a question, I believe, for the supplement organizers. The question is, what would you attribute the recent change in the public health framing and awareness of the issue of human trafficking? Is there anything non-medical direct service providers can do to help continue centering this issue for providers and the public who typically are less informed?
I'm happy to jump in here on this. So the answer is yes, we are all part of shaping the narrative, right? And your interactions with other community members, with family, those that are in your sphere of influence, all matters for changing the conversation. There are some great resources, including videos and narrative that help to frame the issue as a public health issue. I was trying to madly Google for Office of Trafficking in Persons has like a really great, like just a short blurb video that I think really gets at the heart of the matter. But to me, the shortest thing is just to describe that we can't be playing whack-a-mole anymore. We need to go upstream to get at the root causes of the problem. And I think everyone can kind of understand that visual, that if we're not getting at creating at the roots of where the problem is being created, it's just going to continue to propagate. But I encourage the folks from OTIP who are on to share that video, and love the discussion around changing narrative.
Okay, thanks. Another question, this is for anyone. Aside from lack of focus on racism and or labor trafficking, are there other gaps in information that would be important to shift focus on to improve our ability to decrease human trafficking domestically?
Maybe I can start off, and there might be other people that want to jump in. I think that some increased attention to the pathway from detection all the way to service delivery is important, because I think, one of the issues that we have is that we put a lot of emphasis on identifying problems and then trying to figure out what to do about them is something that's left for someone else. And so I think if we had teams of researchers that were working together to kind of connect the research around the epidemiological research and the research around detection to actually how services are delivered and how people get better, and the types of treatments they need, I think that's an area that has not really received as much attention as it needs.
All right, would anyone else like to add to?
I would just add to that the importance of education, provider education. So, making sure that people create that understanding early on that they can then translate in their practices, because they're going to be the people who are probably directly interacting with people experiencing trafficking, outside of the legal system, are going to be educational settings and often medical settings.
Okay, anyone else? Okay, I have a question, and this is for anyone on the panel. What advice would you give to young researchers in this space who are looking to have impact?
I can jump in here on this one. A couple of pieces of advice. One is pay attention to, in this really important dire space, what particular small issue gets you up out of your seat. As you listened in today, what really bothered you, what got under your skin, because that is the thing that will compel you to continue doing the work. Do your homework, learn what is known, what is not known, question assumptions, be critical, ask tons of questions, and learn from the research that we have from other forms of violence. And then after that reflection, listen to community, listen to those who are vulnerable to trafficking. And with that reflection, figure out what is the piece that you really feel called to do.
Would anyone else like to add to that?
Sure. Don't give up. This is not for the faint of heart. Both as a provider, as a researcher, it's challenging work. Find your community that can also support you and encourage you. I'm still in the field because I had mentors that said, Makila, if this is your passion, even if you're not going to get that multi-million-dollar, multi-year large grant, pursue it, because this is what you are most interested in. And so persist, keep trying, build your community. And it is hard work. And it's hard work because if you're doing this work, you care about the population. And sometimes there are losses. And I say losses in terms of if you think you're going to go in and like fix everything, that's not, I don't use that as my measure of success. So incremental, movements. If a child that I was working with before calls me or reaches out after not hearing from them for a long time, that's a win. Having a tough conversation about racism with a practitioner who wants to see how they can do things differently. The change might not be immediate, but that's a win. So those would be my couple of nuggets.
And maybe I could just jump in and just say, and check your biases. We all have them. No matter how hard we work, we're always going to be carrying something of our privilege or our particular perspective. And so think about who on your research team holds you accountable and how do you hold each other accountable? And what are the mechanisms you can build into your research designs to check for any kind of unconscious bias or error in interpretation that might happen. I think I wasn't taught to do that when I was being trained as a researcher, and I think that's an essential piece of what it means to be a good empiricist.
Thank you so much. I'm sorry to say we have no more time for the additional questions. I encourage our participants to contact our panelists directly if the question pertains to them, for them to respond to the question. So first of all, thank you for joining us today. You may access the full special issue. It's listed here on the slide. So I won't read it out, but you'll see it on the slide. A special thank you to the speakers and their staff for their time and contributions addressing the major health challenges facing the United States today. I also want to thank the Association of Schools and Programs of Public Health, our staff at Public Health Reports, and the Office of the U.S. Surgeon General for their continuous support. This is the end of the ASPPH Presents Public Health Reports Meet the Author webinar. As a reminder, this webinar will be archived on the ASPPH website for future viewing. Thank you so much and have a very good day.